Round 3, question 1. A 65-year-old woman presents with pain over her right temple, which is worse during the night. She can't sleep with the right side of her face touching the pillow and complains that she's been feeling generally unwell for some time now. And she has general aches and pains. On examination, you note that her scalp is very tender and the skin over her temple is red. She has a light fever. What is the most likely differential? So a 65-year-old woman presents with pain over the right temple, which is worse during the night. She can't sleep with the right side of her face touching the pillow and complains that she's been feeling generally unwell for some time now. And she has general aches and pains. On examination, you note that her scalp is very tender and the skin over her temple is red. She has a light fever. What is the most important differential? Question number 2. Are migraines classically unilateral or bilateral, throbbing or squeezing, frontal or temporal? Are migraines classically unilateral or bilateral, throbbing or squeezing, frontal or temporal? Question number 3. 3 of the following symptoms commonly occur 24 hours before a migraine. Which one doesn't? A. Low mood. B. Heightened mood. C. Food cravings. D. Fainting. So 3 of the following symptoms commonly occur 24 hours before a migraine. Which one doesn't? A. Low mood. B. Heightened mood. C. Food cravings. And D. Fainting. Number 4. A patient presents with 20 minutes of acute vertigo, which resolves and is replaced with a throbbing headache. What is the most likely differential? So a patient presents with 20 minutes of acute vertigo, which resolves and is replaced with a throbbing headache. What is the most likely differential? And our final question. Is a tension headache usually made better or worse with exercise? So is tension headache usually made better or worse with exercise? So let's look at those answers. So a 65-year-old woman presents with pain over her right temple, which is worse during the night, and can't sleep with the right side of her face touching the pillow. So we've got the hyperalgesia there. She complains that she's been feeling generally unwell for some time now, which is often an indication of some kind of inflammatory situation or infection. And she has general aches and pains. General aches and pains, again, we start to think, like an inflammatory process occurring. On examination, you know that her scalp is very tender and the skin over her temple is red. She has light fever. So, of course, the differential would be temporal arthritis. It has a association with polymyalgia rheumatica, which is why she's getting those general aches and pains. And it's an important one to know because there's a high risk the patient will go blind if it's untreated. Now, temporal arthritis doesn't have to just occur at the temple. It can also occur at the occiput. So, how many patients do we see who complain of occipital headaches? So it's really important to listen to the rest of the symptoms and not just assume because it's occipital, it must be C0 or C1. We want to look at the skin as well. Can you see, really try and move the hair and see, is there anything there? And how do they react when you're touching it? Is it you're giving them a poke, really palpating and saying, oh, yeah, that's tender? Or is it just lightly running your hand over and they're going, oh, God, it's really painful? So palpation really can tell you a huge amount, and pain pressure thresholds are really very, very important. So number 2, are migraines usually unilateral or bilateral, throbbing or squeezing, frontal or temporal? Of course, they are normally unilateral retroorbital pain, so frontal or behind the eye, and they are throbbing. Now, the issue with that is that would be a classic migraine situation, but they have, a wide variety of presentations. If we're just talking about headache and migraine, not talking about all the auras that can come with it, again, migraine can also present as an occipital headache, but in that case, it tends to be more squeezing and tight rather than throbbing. So it's really important to know your headaches and recognize that they're not all cervicogenic. Which of the following symptoms don't occur 24 hours before a migraine? And it's fainting. So migraine, again, is a bit of a monster. So some of the prodromal signs we get there are irritability, depression, euphoria, yawning, increased need to urinate. We get food cravings, photophobia, phonophobia, problems with concentrations, fatigue, muscle stiffness, aphasia, and just like a million other symptoms. Nausea is another very, very common one. The patients often complain they had a bad night's sleep before a migraine. It's important to know this stuff because patients often will blame themselves. So they'll say, the day before, I felt fantastic. I had a great day. I just smashed through my to-do list. I went out, I exercised, I saw some friends. I had just the best day. I've not felt like good in ages, but I overdid it. And the next day I crashed. And it's important to tell them the migraine was already in its first phases. It was in the prodromal phase. That euphoria was part of the migraine. You didn't do anything wrong at all. You could have stayed home and been super sensible and done everything you could to avoid that migraine, and it might still have occurred. So it's really not your fault. People who are having migraines already have a limitation on their life and suffer. So we don't want to add to that suffer by saying, oh yeah, especially when we've promised them that we can get them better. Because patients often say, oh, I was so much better after your last treatment. I was feeling really good. And of course, I've ruined it. I've gone and made it worse. And it's not their fault at all. It's really on us to say, no, that's not what happened. A patient presents with 20 minutes of acute vertigo, which gradually resolves and was replaced with throbbing headache. That sounds like a lot like a vestibular migraine. So vestibular migraine, again, we've had a bit of a migraine session or a headache session here. That would be your textbook definition. Now, it used to be that BPPV was the most common presenting form of dizziness to clinicians, but vestibular migraine has become increasingly recognized and now has replaced BPPV as the most common. So the shame about that is BPPV is very easy to diagnose and very easy to treat. You get a super high success rate with that one. Vestibular migraine is not nearly successful. It has a wide range of presentations, so patients will often complain of vertigo, but all kinds of weird symptoms with it, especially fatigue, brain fog, just feeling rough and tired and having trouble driving, going to supermarkets, all kinds of horrible symptoms. And number 5, it's tension headache made better or worse through exercise. It's usually better in the long term, but it can be worse in the short term. So we want to do exercises that are appropriate for that patient, that don't maybe involve maximum contraction, that are going to increase tension a lot. We want to do things that are maybe cardiovascular and not so intense. So things like yoga would be good. Running can be great as well, just as long as they're doing a good breathing pattern, they're not hiking their shoulders up around their ears. So, round 4. What is the average delay from the first symptom to diagnosis for an intrinsic spinal cord tumour? 1 to 2 years, 2 to 3 years, 3 to 4 years, or 5 to 6 years? So what is the average delay from first symptoms to diagnosis of an intrinsic spinal cord tumour? 1 to 2 years, 2 to 3 years, 3 to 4 years, and 5 to 6 years. Question 2. The MITS phenomenon occurs with flexion of the neck, causing a shooting electric sensation into all four limbs. What condition is it most associated with? So the MITS phenomenon occurs with flexion of the neck, causing a shooting electric sensation into all four limbs. What condition is it most associated with? Question 3. A patient presents with tingling paresthesia in the fingers, toes and lips. On examination you find brisk reflexes globally. What non-pathological syndrome might be responsible? A patient presents with tingling paresthesia in the fingers, toes and lips. On examination you find brisk reflexes globally. What non-pathological syndrome might be responsible? And question 4. A patient complains of fasciculations in the hands, face and legs. How would you differentiate between benign fasciculations and motor neuron disease? So a patient complains of fasciculations in the hands, face and legs. How would you differentiate between benign fasciculations and motor neuron disease? And question number 5, is pain part of the motor neuron disease presentation? Is pain part of the MND presentation? And because that's just a yes or no answer, I'm going to give you a little less time on that one. So let's look at the answers for round 4. What is the average delay for first symptoms to diagnosis of an intrinsic spinal cord tumour? It's 3 to 4 years. It's a long time. The symptoms will start slowly and progressive back pain, but the pain is horrible. The pain is like a deep burning pain. So when we have that tumour that's slowly growing, it's going from the kind of central canal and spinal cord, and it's starting to grow outwards, and it hits those pain and temperature pathways as they go across. So you might find on examination that at that level, maybe going say around the chest, you'd have a loss of pain and temperature. So the patient may notice that if they have a bath. As they get into the bath, they notice, oh, it's hot, hot, hot. Oh, I don't feel anything in that spot. But for most of us who have showers, they may not notice that for a very, very long time. And the way they describe that pain is a horrible, my bones are on fire. It feels like my muscles are being pulled off my bones. Really horrible pain. And then, of course, you'd have all your red flags there. It doesn't get better with position, worse at night, nothing they can do. Painkillers don't touch it, all that kind of stuff. The MITS phenomenon, what's it most associated with, is MS. So MS is the most common, but any form of myelopathy can do it. So cervical spondylotic myelopathy can do it. An intrinsic spinal cord tumour could do it as well. Patient presents with tingling paresthesia in the fingers, toes and lips. Brisk reflexes, what non-pathological syndrome might be responsible? It's hyperventilation syndrome. So very simply, when someone starts hyperventilating, they blow off all their CO2, they go into respiratory alkalosis and basically their nerves become jumpy. So the sensory nerves around the lips, around the fingers and around the toes start to become jumpy. That's where you get numbness and tingling. But also the motor neurons become jumpy, and that's why you get these brisk reflexes. Important one to know, and actually really quite common, especially in this time of anxiety and stress. Worth knowing that one.